Hello, I'm Dr. Shilpa Gupta. I'm a genitourinary medical oncologist at the Cleveland Clinic, and it is my honor to join Dr. Neil Love today to discuss the year in review, clinical investigator perspectives on the most relevant new data sets and advances in the bladder cancer edition. Addressing unmet needs in non-metastatic urothelial bladder cancer is really has been a key priority over many decades, and we've seen so much progress in the last year. And this is really a much needed effort because only a third of patients with non-muscle invasive bladder cancer actually receive intravesical BCG. And even if in a country like the US, we are struggling with BCG shortages, which affect access to this. And in patients with muscle invasive bladder cancer, over 50% patients may not receive curative intent therapy globally. And there's a high risk of recurrence in MIBC despite neoadjuvant cisplatin based chemotherapy and surgery. And 50% patients are not even eligible for neoadjuvant cisplatin based chemo. And about a third of patients refuse neoadjuvant chemotherapy. Furthermore, patients who are not eligible for neoadjuvant chemotherapy, which is cisplatin based, do not have any neoadjuvant treatment option to date, and upfront surgery is what they get. And radical cystectomy in general, even in the best of hands, can have a significant mortality and morbidity and long term negative impact on sexual function, quality of life, and a lot of emotional distress, in addition to the risks associated with surgery in the short term. And development of effective, safe, and durable treatment for non muscle invasive bladder cancer and muscle invasive bladder cancer, as well as focusing on bladder sparing treatments, is an unmet need. We'll start with the non muscle invasive bladder cancer, and this space has really exploded in the last 5 years. In the past, this used to be a surgeon's disease, and now with the advent of novel therapies, it's become more of a multidisciplinary disease with medical oncologists playing an important role in this. We first had the approval for pembrolizumab in BCG unresponsive non muscle invasive bladder cancer back in 2019 based for patients who had carcinoma in situ. And now we saw the cohort B results from the Keynote 057, pembrolizumab for papillary high risk NMIBC. And in this, we saw there was around 132 patients enrolled. Median follow up is still short, around 4 months. And we saw that the 12-month complete response rates were 43.5%. And at year 2, it was close to 35%, which is quite impressive because we saw that in the other cohort, efficacy does fall over time. And this is another very novel study in BCG unresponsive patients where they looked at combining immunotherapy durvalumab with or without BCG or with external beam radiation therapy, which is quite novel for patients with non muscle invasive bladder cancer. And this was the GU16243 ADAPT bladder study led by Dr. Han and colleagues, in which patients got durvalumab every 3 weeks for 8 cycles, plus minus BCG induction and maintenance as standard. And patients who were in the EBRT arm received concurrent EBRT of 6 grays times 3 doses in cycle for 3 days in cycle 1 only. And the primary endpoint was to get a recommended phase 2 dose for each regimen. Secondary endpoints were toxicity and complete response rates. 28 patients were enrolled. 3 patients got durvalumab alone, and 13 patients got durvalumab and BCG. 12 patients got durvalumab with radiation. So in this study, we found that the recommended phase 2 dose was full doses of all these modalities: full dose durvalumab, full dose BCG, and radiation 6 grays. There was one grade 3 treatment related adverse event of autoimmune hepatitis, and the 3-month complete response rate for all the patients was 64%. And if we break it down to treatment modalities, it was 33% for durvalumab, 85% for durvalumab and BCG, and 50% for durvalumab and EBRT cohorts. And when we look at the 12-month CR, it was 46%, so much lower than the 3-month CR rates. And durvalumab and BCG had 73% CR rates at 12 months, and durvalumab and EBRT had 33% CR rates. So this is hypothesis generating data, and more prospective trials are needed. Dr. Love?
So is this now in a phase three trial? And also, don't know that I've heard about external beam radiation therapy for non-muscle invasive bladder before. Is that done?
No, it's not. And that's why this was a very early trial, and really a phase one setting, just to establish the safety for this modality. And we have never done this before.
Hmm, that's really fascinating. Do you know if there's a phase three trial?
I'm not aware of the phase three yet. Probably they'll keep expanding this and do the phase two dosing first. And, the landscape is changing so much with other intravesical agents. I don't know where this will fit, but this was certainly interesting to see that it can be done.
Well, the other thing that's kind of interesting is they're using BCG even though they're not responding to BCG.
Right. And we have seen other trials like the Quilt study too, and I think that's a very valid point, especially in countries like the US where there's BCG shortage. And I think the way the mechanism for durvalumab works, though, is I don't know if you really need to combine it with BCG in BCG unresponsive NMIBC, because we have seen activity of single agent immunotherapy. So I think, regardless, by itself, it didn't look like it was that effective in this. So we are seeing a lot of novel approaches coming along in NMIBC with novel agents and radiation, as we just saw. And a very novel device that we have seen shown efficacy is called the TAR 200 intravesical drug delivery system. And here's the picture of it. It actually looks like a little pretzel, which enables a sustained release of drug. TAR 200 specifically is for gemcitabine, which is placed in the bladder, and then it is released in a sustained fashion over time, and it increases the dwell time of the local drug concentration. Now, I want to highlight here that intravesical gemcitabine has been used in the bladder for a long time, but that's not a sustained release formulation. So, this trial, the phase 2 Sunrise 1 trial, enrolled patients with BCG unresponsive, high risk NMIBC with the good performance status, with or without papillary disease. They could have T1 or high grade TA, and these patients were ineligible for or declined radical cystectomy. And the key eligibility criteria for this cohort was high risk NMIBC papillary disease only for cohort 4, where they got TAR 200. And cohort 2 is what I mentioned earlier, was a 80 patient cohort. Primary endpoint for cohort 2 was overall complete response rate, and key secondary endpoints are duration of response, overall response, and safety. And for the cohort 4, the primary endpoint is disease free survival rate. There are also two other cohorts in this study in combination with a checkpoint inhibitor. So, we are going to talk about the Sunrise 1 study in the cohort 2. The complete response in patients with high risk NMIBC with CIS was 76.7% in 23 patients. And this was centrally assessed in the investigator assessed response was 80%. And this was very well tolerated. Mainly, there were just some low grade 1 or 2 adverse events, manageable urinary symptoms, and it was very infrequent to have a grade 3 or higher adverse event leading to discontinuation. And as we can see here, the treatment duration and response, the median duration has still not been reached. And the median follow up was 48 weeks in the responders. And the estimates for the duration of response are about 93% at 6 months and 84% at 12 months. And 21 out of 23 responses are still ongoing. So, this is a very promising agent. It has a breakthrough designation by the FDA and really being explored in MIBC as well. Want to highlight here that FGFR is an attractive therapeutic target in NMIBC. And if we look at this picture, we see that while in metastatic disease, FGFR overexpression is seen in less than 20% patients, it's highly expressed in non muscle invasive disease compared to metastatic disease. And about 30% patients with high risk papillary NMIBC have FGFR alterations, and hence it's a rational approach for targeting. So there's two options. There's the systemic FGFR inhibitor erdafitinib, which is also approved in metastatic setting, and then there's this drug delivery system like the TAR 200. This is called TAR 210. It has erdafitinib as the slow release formulation within the bladder, and it can just stay there for 3 months. So we spare the patient of the systemic toxicities, which are quite a lot with the oral erdafitinib. This is the TOR 2 study, cohort 1, where oral erdafitinib versus intravesical chemotherapy was studied in BCG unresponsive high risk NMIBC patients. So I'll discuss the study and the toxicities that we saw with erdafitinib. So basically, patients who screened for FGFR mutations or fusions in the tumor tissue were enrolled, and these patients had NMIBC with recurrence after BCG therapy. I want to highlight here that this is the first trial that used the classic definition for BCG unresponsive in the box below. That is, patients had recurrent high grade TA or T1 disease within 6 months of completion of adequate BCG therapy, which is 5 or more of 6 full doses of initial induction, including 1 or more of maintenance course, or 5 or more of 6 full doses at initial induction course plus 2 or more of 6 doses of second induction. In addition to this definition, they also included BCG experienced patients, which means patients should have recurrent high grade TA or T1 disease within 12 months of completion of BCG therapy. And prior BCG is defined as greater than or equal to 5 of 6 full doses of initial induction, or 5 or more of 6 full doses of initial induction plus 1 or more maintenance course in a 6-month period. And half doses or one third doses were also allowed. And this is more of a real world setting where everybody doesn't fit the criteria for the BCG unresponsive based on the timing. So in this cohort 1, we had high risk NMIBC patients without CIS, and they were randomized to erdafitinib 6 milligrams a day dose or investigator's choice of intravesical gemcitabine or intravesical MMC or hyperthermic MMC. I would like to highlight here that in the early phase of this study, higher doses of erdafitinib were tried. They were far too toxic, and 6 milligrams a day was the dose that was chosen. Despite that, the trial was stopped early due to slow accrual and toxicity issues. Primary endpoint was recurrence-free survival. As we can see here, in terms of efficacy, at a median follow-up of 13.4 months, the median RFS was not reached for erdafitinib, and it was 11.6 months for chemotherapy. And at the clinical cutoff, 25 total RFS events had occurred, 11 with erdafitinib and 14 with chemo. When we look at the rates at 6 months, it was 96% of recurrence-free survival rate with erdafitinib compared to 73% with chemo. And at 12 months, it was lower than 6 months, but still 77% versus 41%. So this is quite promising, right? But when we look at the safety, and even at this low dose of 6 milligrams, you can see that majority of patients, over 3/4, had nail toxicities, which can become really bad, associated with a really bad day to day quality of life, hyperphosphatemia, eye toxicities, which can be very significant, dry mouth, skin toxicity, and central serous retinopathy, which can occur in up to 39% patients, and grade 3 or higher in 4%. And this is something very concerning. And that's where the TAR 210 comes into the picture. And this is the study that looked at that with patients who had archival tissue or urine cell free DNA tested for NGS. And in this, there was cohort 1, which was high risk NMIBC, who were BCG experienced or unresponsive and not receiving radical cystectomy. But they required to have a complete resection on TURBT of all visible disease prior to treatment. And in cohort 3, patients with intermediate risk NMIBC were enrolled, those with recurrent and history of low grade only TA or T1 disease as well. And again, visible target lesions prior to treatment was allowed. So in the dose escalation Bayesian-based design, there was two dose levels, TAR 210B, which was the dose level 1, and TAR 210D, dose level 2. And part 2 was the dose expansion. Primary endpoint for this early phase study is safety. So we saw that the steady state mean plasma concentrations are 50 times lower with this intravesical delivery system compared to oral erdafitinib of 9 milligrams daily. There was no hyperphosphatemia seen, which is a really big advantage because we have to continuously monitor patients on oral erdafitinib. And this provides sustained erdafitinib release in the urine over 90 days with very low plasma concentrations, as you can see on these graphs of the urine and the plasma. And when we look at the efficacy in cohort 1, the FGFR altered high risk NMIBC patients, there were 16 patients enrolled. Primary endpoint was recurrence free survival, and it was 82% here, and median recurrence free survival was not met here. As you can see here, median duration of treatment exposure was 4.3 months in the dosing of TAR 210D, and median duration of treatment exposure was around 3.7 months in the other dosing. So these are still, very few patients, but we are seeing encouraging activity. And in intermediate risk patients in the cohort 3, we saw complete response rates of 87%. And this is still not a long follow up, so just hypothesis generating. And now we'll talk about the other novel agent, antibody drug conjugate enfortumab vedotin, which is already approved in advanced setting, both in refractory setting and now in frontline setting, along with pembrolizumab. Um, this study is exploiting its use in non-muscle invasive setting. Now, just for refreshing, it's an anti-nectin 4 monoclonal antibody, and the MMAE is the active agent, and these are linked by a protease cleavable linker. And when this agent goes inside the cell, there is endocytosis, MMA is released and causes microtubule disruption and apoptosis. So this is the study EV104, where there's intravesical use of enfortumab vedotin. So this is not systemic use. Again, the first of its kind study here. So patients who had BCG unresponsive CIS with or without papillary disease, either unfit or refusing radical cystectomy, ECOG performance status 0 to 2, they received induction with intravesical EV, 25 mils weekly for 6 doses, and then went into a maintenance phase uh, from months 4 to 12 every month for 9 doses. And they followed up. Primary endpoint was safety, tolerability, feasibility, and the PK PD parameters. And secondary endpoints was clinical efficacy. So as we are in this first in human study, the dose escalation phase identified the maximal tolerated dose, at different levels. So 125 milligrams, 250, 500, and 750 milligrams. And the study design was optimized to maximize the intravesical drug concentration and limit urinary urgency with a 25 milliliter dose volume, which is manageable. And approximately 18 patients are planned to be treated across these four dosing regimens. And as of the data cutoff from last year, 6 patients had been enrolled and received EV at the first two dose level. So this study is still going on, and this is very early interim data. As we can see here, only 6 patients were enrolled. All 6 patients completed the DLT period, and there were no DLTs observed at the first two dose levels of 125 or 250. And the treatment related adverse events that we saw in this interim analysis was fatigue, dry eye, and micturition urgency. And this brings to that question, Dr. Love, of why is it causing the eye toxicity if it is staying within the bladder? So that's really interesting. And that makes me wonder if it's because of the pretzel that, we are limiting the seepage into the plasma. Fortunately, there were no grade 3 or higher treatment related adverse events. There were no treatment related SAEs and no treatment related adverse events that led to dose discontinuation or reduction. And when we look at the preliminary efficacy here, patient 3 had persistent disease at 3 months, was allowed to stay on treatment until the 6 month assessment here. This is, only 6 patients, so it's really difficult to generate data. But we do see that at the time of cutoff, this one patient was also not evaluable, patient number 6. And the patient did complete all planned doses of EV here, and 3 achieved a CR at the time of analysis. So out of 5 evaluable patients, we are seeing CR in 3 patients. Very, very early data, limited follow-up. So we'll have to keep on the lookout for the follow-up results from this study. So that was what we saw in the non-muscle invasive bladder cancer, and I'm sure we'll see some follow-up this year. Now, switching gears to muscle invasive bladder cancer, where also a lot of activity is going on. When we look at the adjuvant immunotherapy based trials in high risk muscle invasive urothelial cancer, defined as, if a patient got neoadjuvant cisplatin based chemo, then their final pathology had to have YP T2 to T4A or node positive disease. And if they did not receive cisplatin based chemotherapy, then they had to have PT3 to T4A or node positive disease, and they could decline adjuvant cisplatin also. So we have these 3 big trials here. The IMvigor 010, which used the anti-PD-L1 antibody atezo versus observation, primary endpoint disease-free survival, secondary endpoint overall survival, and other clinical endpoints. This was a flat out negative study. No disease free survival or OS improvement was seen. Then we have the Checkmate 274, which is with anti PD-1 nivolumab versus placebo. Primary endpoint again DFS, similar patient population. We saw improvement in DFS, but we have not seen any overall survival data. And it has been over 3 years since it was reported. More recently, we saw the third trial results, the Ambassador study, which is also anti-PD-1 agent pembrolizumab versus observation. There were co-primary endpoints of DFS and OS, and again, in all comers, as well as PD-L1 positive and negative. We saw at ASCO GU that there was disease-free survival improvement, and at the first look of the data, there was no OS improvement. Now we saw the Checkmate 274 extended follow-up, which was presented in 2023. We saw that in intention to treat patients, the median disease-free survival was 22 months with nivolumab versus 10.9 months with placebo. So it was pretty similar to what we saw early on. In PD-L1 positive subgroup, the median DFS was significantly higher at 52.6 months with Nivo versus 8.4 months with placebo, hazard ratio 0.52. I want to highlight here that in the US, this is approved for all comers, but in Europe, it is only approved for PD-L1 positive patients because of this, as well as unnecessary financial toxicity. And I also want to highlight here that in the subgroup analyses in the forest plots, we saw that patients who derived benefit from adjuvant nivolumab were those who had received neoadjuvant cisplatin based chemo. As we can see here, hazard ratio was 0.52 for those who received NAC, and it was 0.92 for those who didn't.
I was just curious, did they show in 274, did they isolate out the PD-1 negative patients?
Yeah, they did at the AUA. They showed the PDL1 negative subgroup, and it did not show as promising activity as the PDL1 positive. And we also saw here that only patients with the bladder cancer derive benefit. Patients with upper tract disease, there was absolutely no benefit, and it is still approved in those patients here. Um, and this is the cohort that they presented at the AUA last year, focusing only on MIBC. And here we see that with nivolumab, the median disease-free survival only in the bladder cancer patients was 25.8 months versus 9.4 months with placebo. And that brings us to this big question whether it should be used for all comers. We know it doesn't work if patients don't get neoadjuvant cisplatin based chemo, does not work in upper tract. And we've seen it work so much better in PDL1 positive patients. So, really, we are left with a very small subset that may benefit. And um, we have not seen any overall survival data to date. So I think the big question is whether, what is the utility of an adjuvant therapy if we don't have OS benefit? And I've seen some press release that we may see the first OS data at EAU. So we'll stay tuned.
Do you generally, in your own practice outside a clinical trial, what do you do in those situations? PD-1 negative, upper tract disease. Do you present it to the patient, and if they're willing to make it and participate, allow them to decide? If they ask you what to do, like what do you say?
So I don't test for PDL1, but for upper tract disease, I don't offer it. I offer
You don't
platinum
know.
based chemo based on the POUT study where it shows disease free survival benefit. And I also talk to patients about, that in the IMvigor 010 study, we saw that the benefit was only in the ctDNA positive patients. So we try to enroll them on our ctDNA study of, that we have right now, IMvigor 011. But we want to present the data to the patients that there's no OS benefit reported, and we have all these very effective therapies in frontline settings. So, and the patient makes an informed decision.
In these cases, do you offer ctDNA outside a trial to the patient?
Yes, we are. I'm not using that for decision making, but we are doing in the adjuvant setting to monitor, the ctDNA. It is an approved modality.
But I mean, like for example, in a PD-1 negative case, for example, would you look at cell-free DNA in addition to that
Yeah,
before
I would.
deciding?
Yeah, I do gather all that information and then we discuss with the patient and then we serially
Interesting.
monitor.
Please
Although,
continue.
per the label, we don't need to do that,
Right.
but I think it's good to understand the dynamics.
I was going to say very similar things going on with cancer, the gastroesophageal cancer,
Hmm.
where it's approved regardless of PD-1, but just like here, you don't see benefit. There, even the NCCN says don't use it. But that's why I was curious. So I guess they haven't gone that far here.
No, yeah, not in the US. And in the ambassador study, where pembrolizumab was compared to observation for again high risk uh, urothelial cancer. It included upper tract as well, like the other studies. There was a median DFS of 29 months versus 14 months, hazard ratio 0.69. And in this study, we saw that there were higher rates of neoadjuvant chemotherapy, probably because this is all in the US, right? And there's higher utilization. So it is possible that that's why the median DFS was higher than what we saw with nivolumab. We have not seen any overall survival at this first interim analysis. Unlikely for it to become positive later, but we'll stay tuned for that. And now comes again enfortumab vedotin monotherapy in the neoadjuvant setting for patients with cisplatin ineligible muscle invasive bladder cancer from the EV103 cohort H. So EV103 was this huge multiple cohort study, and cohort H looked at EV alone. I have to highlight here that typically for deeming somebody cisplatin ineligible, we go by the creatinine clearance less than 60, hearing loss, heart failure, neuropathy, poor performance status. Here it was interesting that 50% patients were deemed ineligible due to creatinine clearance less than 60, but 40% were deemed ineligible because of hearing loss. In our routine practice, that is not that high a number. And also, when patients have hearing loss and we talk to them about curative approaches, they usually okay with getting cisplatin. And I think when you go look for hearing loss, you will find more, but typically, we are not really doing a hearing test on everybody. So that was interesting, and I wanted to point that out. In this study, the PCR rate, first of all, the to highlight the EV monotherapy dose, it was 3 cycles before surgery, and path complete response rate was 36.4%. This is something we have also seen with single agent immunotherapy, pembrolizumab and atezolizumab, something like in this range. And 19 out of 22 patients completed all 3 cycles. There were no noted delays to surgery, but there was one death from acute kidney injury in this small cohort. So something to be cautious about. And another trial similar in this cohort, EV103 cohort L, is the perioperative treatment with EV monotherapy. So in this, they get neoadjuvant 3 cycles of EV, and then they also get 6 cycles in the adjuvant setting. And primary endpoint is PCR rates. And interestingly, I want to mention here that, if let's say somebody has a complete response to neoadjuvant EV, we really don't know what is the rationale of giving them EV in the adjuvant setting then, but that the study, that is how it was designed. And 51 patients were treated, and patients who completed all 3 cycles, 42. So, not everybody can complete all 3 cycles even. So we need to be cautious. And again, the PCR rates were 34% and downstaging rates were 42%. Nothing different from single agent immunotherapy. But I want to point out here that the toxicity was quite significant. There were 57% patients had skin reactions, which is expected, but there was one death from Stevens-Johnson syndrome, and there were 33% patients had significant peripheral neuropathy. Now, in this setting, are we over treating with adjuvant if we don't need to? I think that is a question the phase 3 trials will also not answer for us.
So you said that the single agent IO neoadjuvantly causes those kinds of path CR rates? Like
Yes, like if
30%?
the pure,
30%.
yes, right. Pure O1 study with pembrolizumab showed that. Abacus study showed that. So,
And the other thing I was curious about is, this death from Stevens Johnson. Globally, if you had to come up with a number, I mean, it's only 51 patients. That's 2%. But what would you say the number is of, a much larger number of patients, severe skin reactions, maybe not
Yeah.
completely. What number would you give that?
I think it's less than 6-7%, but in the post registration trials and registration setting in France, they had seen, I think, three deaths from skin reactions in the early EV monotherapy studies. Although in the frontline EV Pembro study, we did not see any deaths from skin reaction, so that was good. I'll say it is still rare, but it's something we have to be very cautious about.
Well, I mean, I'm hearing more and more about the skin issues, and one of the things I was just sort of flashing on is how much concern, TDXD with HER2 positive disease people have about interstitial lung disease. And here you're seeing deaths also from toxicity, and
Hmm.
maybe not as many, but they're not that many. When you think about all the attention TDXD gets for interstitial lung disease, I wonder if maybe this ought to get more attention. I don't know.
It should. It should. That is, I think it is our responsibility. And, the peripheral neuropathy I want to highlight can be very disabling with this because patients underreport their symptoms. And when you actually make them walk, you're seeing that they are falling and then you dig into it. So, as a practice, I do a full skin exam of patients and make them walk because this drug can be very toxic, and especially in this setting, where we're aiming for a cure, and
Sure.
we see these toxicities. And now we are back to the use of TAR 200, which we first discussed in the NMIBC setting in Sunrise study in muscle invasive bladder cancer. So, really a unique setting, the first time used in patients who were unfit or refused curative intent therapy. So, this was a phase 1 study. It's called TAR 200-103. It's a global study, patients with C2 to CT3B and 0M0 urothelial cancer who got 4 consecutive 3-week cycles of TAR 200 over 84 days. Primary endpoint was safety and tolerability. And then we had secondary endpoints of complete response, partial response, duration of response, etc. And again, showing the mechanism of action here. So, out of the 35 enrolled patients, there were some TAR 200 related treatment emergent adverse events, which are notably urinary symptoms like dysuria, urinary frequency, and generally it was very well tolerated with only 2 TAR 200 removals unscheduled, that is, before 3 months were over. And overall, 11 patients had CR and 3 patients had PR. Median overall survival was 27 months. Median duration of response was 14 months. Overall response rates were around 40%. So, this is again hypothesis generating data. Conclusions were that TAR 200 is safe and well tolerated in early elderly patients with muscle invasive cancer who refuse surgery or curative intent therapy, and it shows some preliminary efficacy. And there are trials going on in MIBC space with TAR 200 and immunotherapy combinations. And this is again showing the results from that. And now, in the topic of muscle invasive bladder cancer organ sparing treatment, this was a pivotal study, the Hoosier Cancer Research Network GU16257, led by Galsky and colleagues, in which they used gemcitabine, cisplatin, and nivolumab, and then proceeded for organ preservation when possible. So, patients got 4 cycles of neoadjuvant gemcis nivo. Primary objectives were clinical complete response rate and really a complicated algorithm to calculate the positive predictive value of a clinical CR for a composite outcome, which was 2-year metastases free survival in patients who forego immediate cystectomy or less than YPT1N0 in patients electing immediate cystectomy. As we will see here, very few patients elected immediate cystectomy who got clinical CR. Only one patient elected. So 76 patients were enrolled. 33 achieved a clinical complete response, which is 43%, and 32 out of 33 opted to forego immediate cystectomy as expected. The positive predictive value of a clinical complete response was 0.97. Thus, it met the co-primary endpoint. This is showing here the metastases free, landmark survival, overall survival. So this was an important hypothesis generating study, and we need more of such studies to offer to our patients.
Just to clarify, so these patients did not get any kind of radiation therapy then?
No, but subsequently they did. It was not part of the uh, proposed treatment. If they did not achieve a clinical complete response, as we see here in 39 patients, they could get non-protocol therapy. For example, 4 patients got radiation on that cohort.
Do you think it makes sense to do consolidation radiation therapy even in patients who have a past CR?
In PAT CR, I don't think it is needed if they have a PAT CR. But we have another trial through the Alliance Cooperative Group where patients have that option to spare their bladder after a complete response with chemoradiation or surveillance. Um, if they have DDR alterations, they can go surveillance. Otherwise, they can do chemoradiation or surveillance. So I think in patients who don't achieve a clinical complete response, if patients refuse this treatment, then we definitely should offer chemoradiation, though not just radiation.
And also, I guess that there in this trial or other similar trials, are any of these using cell-free DNA? Because that seems like it might be pretty interesting to look at.
I think they are. We've not seen the data, but I think they've collected the blood to see what's happening. And this is the individual patient outcomes who achieved clinical CR and did not. And now this is the study that we saw last year. This came out: perioperative chemoimmunotherapy with durvalumab for muscle-invasive bladder cancer. This was a single-arm phase 2 trial called the SAC 0617. There were 61 patients enrolled with CT2 to T4A and less than or equal to N1 urothelial cancer. uh, the important thing here is it included bladder, urethra, or upper tract. So this was unique in that regard. And this was a truly perioperative study. They got neoadjuvant Gemcis durvalumab for 4 cycles and then adjuvant durvalumab for up to 10 cycles. Primary endpoint was event-free survival at 2 years. I want to highlight here that 94% patients had bladder, only the very few patients had upper tract disease. The 2 year event free survival rate was 75.7% in this study. And when we look at the pathologic responses, we saw that complete responses were seen in 40% of patients who had clinical T2 and in 20% patients who had CT3 disease. And downstaging was seen in, majority of patients actually. So that is pretty nice data. And I think here also, even if patients got a clean pathologic complete CR, they still got adjuvant durvalumab, right? Do we really need that? And this is another study which used durvalumab along with radiation, followed by adjuvant durvalumab after completion of radiation in patients with localized bladder cancer. This was led by Joshi and colleagues. So patients with T2 to T4 and 0 to N2, M0, bladder cancer patients, unresectable or unfit for surgery or cisplatin ineligible, were enrolled, and cis eligible could enroll as well. And so durvalumab was used for 2 doses plus radiation over 7 weeks. And the response was evaluated with biopsy and cystoscopy. And the primary endpoint was progression free survival at 1 year and disease control rate post adjuvant durvalumab, which meant up to 12 months of adjuvant durvalumab was given in this. So we saw here that median progression free survival was 21.8 months. Median overall survival was 30.8 months. It was well tolerated, did not see any new safety signals. And on the left, you can see that disease control rate at 1 year was 72.7%, and the overall response rate was 68%, with CR in 54 and PR in 13% patients. So that brings us to the end of these updates, but I think this highlights how much progress is going on in the field in the localized urothelial cancer space, and there's a lot to look forward to this year.